Today's episode of HIPcast is brought to you by Harris Data Integrity Solutions. Embark on a journey towards unparalleled excellence and reliability in healthcare data management. Harris Data Integrity Solutions merges the expertise of Just Associates and QuadraMed Corporation, paving the way for a brighter future in patient data integrity. You'll have peace of mind that you are working with a SOC 2 Type 2 certified vendor. With SmartIX, achieve a unified enterprise master person index, ensuring seamless patient records across your entire health system with precision and accuracy. CuraMatch offers modern, automated HIM workflow solutions, empowering HIM teams with efficient patient duplicate detection and resolution processes. Streamline your MPI maintenance with Harris's expert teams and tailored MPI cleanup solutions, saving you time and minimizing errors for sustained data integrity. Discover the power of Harris Data Integrity Solutions, shaping the landscape of healthcare data management. Explore their comprehensive offerings today at harrisdataintegritysolutions.com.
Well, welcome to the show today. Welcome, Mandy. Thank you for joining us.
Thank you for having me. It's great to be here.
Yeah, my pleasure. Today's pretty exciting day. We are going to talk all things healthcare data. Mandy Willis is a healthcare data and information management specialist who graduated from WGU with a Bachelor of Science in Health Information Management. She focuses in the public sector. For almost 20 years, she has worked with Medicare and Medicaid programs to promote the standardized use of healthcare data and adoption of health information principles and standards to better align with healthcare providers. She is a champion for leveraging data to support the rapidly changing healthcare landscape and is committed to supporting both public and private sector in coming together to create innovative solutions to our most urgent healthcare needs. And today we're going to talk a lot about all things healthcare data, from data governance to management, current state. I mean, just all the things that, not all the things I love, but man, I do love data governance. I love it.
Me
so
too.
Welcome. I'm so glad you're here.
Me too. I'm really glad to be here. I am, for lack of a better term, a data head. Which just, yeah,
like
anything data is my jam. And
Maybe we need a merch store or something like that for HIPcast, and we could have a shirt that says "Data is my jam" or "Data head." I like that.
Right?
That's fantastic.
I know. I think
I'd wear that shirt.
I would too.
That's fine. Well, there's two of us. We're going to have sales for 2 shirts. So we've made a total of $3 for the THIMA Foundation, but $3 well spent. But I like that. Data is my jam. So let's talk about that. What is the current state of healthcare data? Because I think that it's a tidal wave of information that somebody's got to sift through, and I'm not doing it. So I'm glad there's people like you, Mandy, doing it.
I know, right? I'm right. And it's so funny. Healthcare data is this. It's just a sea of possibilities and potential. So for me, just to kind of level set and give context, I started out as a coder, as a certified coder. And I happened to fall into healthcare data more as an opportunity to explore data from the inside, like what happens when you send your claims in, and how does that all work? What do the systems do? So it was really more of like a curiosity, and then it became a passion because I could see all the ways in which we were not using healthcare data, that we weren't supporting the collection of accurate and valuable healthcare data, meaningful healthcare data, right? So when and that was, of course, like almost 20 years ago. So not a lot has changed. We still have the same issues, same barriers, same obstacles that we had 20 years ago. But all of a sudden, there's a lot of visibility on it. Like there's, and I thought it was crazy for the longest time. Like, why am I the only one who sees this? Why am I talking to people and they just don't understand what I'm saying? Like I have lobsters coming out of my ears. Like what is this? And then I started to meet people that understood what I was talking about. Like all of a sudden we started to get our language made sense to each other. And that gave me the first cue, like, oh, data is all about language. It's all about what we call things, what we name things, how we name them, how we categorize them, right? So when you get down to those fundamentals, it's really just about language. And so all of a sudden I started to be able to speak other people's language. And we could connect at this level that says, hey, do you see this? I see this. Why are we doing it this way? Why aren't we doing it this way? What are the standards for this? How are you supposed to manage this data, right? And there's all of these principles and standards and guidelines and mechanisms for managing data and governing data. And there's this book called the Data Management Book of Knowledge, the DIMBOK, right? And it's got all of this great stuff in it about data, but it doesn't have anything about healthcare data. And healthcare data, while it is also data, is different. It's just different from all the other data that's out there. We focus in on the financial aspects of our healthcare data, right? Because it's a mechanism for paying claims. And that's how we interact with it the most, is through that mechanism. That's where all of our data gets collected, is through that mechanism, right? Unless you're reporting through registries or whatever. But most of our interaction with the data is through that process. So when we look at it and there's this kind of focus on the financial aspects of this data and how we pay claims and what we do with identifying where there might need to be benefits or whatever that is, we're leveraging the data for that. But it's also way more complex than that, because the data that's inside of that inside of those transactions, inside of those claims, they're actually telling a story about a person. It's about an individual, right? And so much of what we do with data is to rip it apart, like tear it apart, and you send it over here and you do this thing, and then you send it over here and you do this thing, but you're not actually looking at the whole thing. So you deconstruct it and then you send it out, and then that's it. And then those little parts and pieces go all over the place, and people use them for different things. But nobody ever puts it back together to look at what the whole picture looks like. And so when you don't put it back together, you miss all of these things that are critical in healthcare data. Like, why is this happening? Or, what is the prevalence of this disease with this procedure? Or, like those kinds of things where there's relationships between the data, between those data sets in healthcare. So what I started to realize was that was the missing piece, was that the data in healthcare, what we are missing is putting everything back together and making it a holistic view of an individual or group of individuals, in a population.
It's very episodic, right? And even to that level, it's even broken down further. So you think about a patient that has a chronic condition, we're looking at every visit as a single source, and then you break that down even further. But what you're doing is pulling it back to the macro level to say, let's look at the past 20 years of this patient dealing with this disease, trying this medication, doing this intervention, and how does that come together, right? That's what you're working through.
Right, exactly. And what are the trends? Yeah.
Yes. Yep. That's very good. That's a very good kind of a level set. And I also have DIMBOK, and I have had some courses with.
Is that the book? Say that again, DIMBOK. I want to make sure everybody puts that on their Christmas list this year, because it sounds like a fantastic read. It's
fantastic,
just below Harry Potter, right?
Yeah, it's super exciting. Page turner.
Very good. If you like data, it's a really good book. But it's a great. I will say, I agree with you. It's an incredible book and the concepts that are in it are really great to help a health information professional understand structures, relational databases, and really how that data is at rest and in motion, right? I mean, I really think it's an incredible setup for us. I love that you recognized the missing pieces is that healthcare data is specialized, right? So if you take those, if you take data management principles out from outside of healthcare, but then you start to overlay the context of data management and really think about it from a data governance and data management perspective specific to healthcare. Talk a little bit about that.
Yeah. It's so funny you say that
Or a
because
lot. Talk a lot about it.
right?
Yeah.
Talk a lot.
I can tackle a little or a lot. It's funny that you say that. So I actually went to, I want to say it was a HEMA years ago. I went to a convention years ago or a conference years ago, and they were talking about information governance, right? And so that was my first kind of foray into governance as a process, as a discipline, and it all made sense to me. But as I got into actually doing work in the environment I'm in, which is at the, the public sector level where we're, claims processing and also benefits development and all of those things, it became clear to me that there is little to no infrastructure around data in this environment. And data governance in healthcare is really a new concept. It's not something, because again, it goes back to, we've long focused on information governance, right? Where we're talking about release of information, how long do we retain records, how do we handle that information, privacy and security, which are all critical components of data governance as well. But there's a whole other level of data governance, which revolves around like the standardization. Are we talking the same language? Because at the basic level of every challenge that I have seen is that we all think we're talking the same language, but we're actually not.
Yes.
That what this means to me over here does not mean the same thing to you on the technical side. Like when you're trying to develop a solution to improve your data, and that requires a conversation about how is the data represented in the system, how is it coming into the system, what are the sources of that data. A lot of times you'll miss that communicate, like there will be a drop off in communication because what's happening on the technical side doesn't really account for how the data gets there, right? It just cares that the data is there. So there's this whole conversation that never takes place around how we actually get that data, how we source that data. When we're talking about the development of benefits, you've got all of these ways in which you can execute benefits within a system using reference data. So code sets, CPT codes, HIPcast codes, ICD-10 codes, right? You've got all these ways to do that. But you're not, you've got all these ways to do that. I'm totally losing my train of thought.
I'm over here having fear because you were saying HIPcast and CPT, and it's like bringing me back to the coding days. And I'm like, oh gosh, those were my worst classes in HIM school.
Yeah, exactly. And that's how I started out. And, just sidetrack ICD-10, I did a lot of work on the implementation of ICD-10 at the public sector level. So, again, data governance at that level does not exist. It's just like, this is a thing that has to happen. I have to comply with this. Otherwise I'm going to get in trouble. And so I don't care. I don't care about how it gets in there. It just needs to get in there. Right. So the lack of data governance really prevents the actual usage of those data sets in a meaningful way within the organization. Again, not just financial, but it's how are you developing your benefits if you don't know, or if you developed policy that had and you don't know how that data is supposed to work within, like how it's going to be sourced. Like, again, going back to who is going to send you that data. That's going to be somebody outside of you that is operating on understandings about codes and how to code. And I, on the benefit side, have no idea what any of that is, right? So I just create a policy and then I tell you what to send me. And then you send me something because you know that that's what's going to get paid. Not necessarily that it's going to give me information or valuable data about this person. It just knows that I'm going to get paid for that.
Coin
And
or
so,
operating.
complete, right? Or complete
right,
information.
Yeah.
right, exactly. So there's this mismatch. So again, we're not
Mhm.
talking the same language. If a payer, and in the public sector environment, and specifically like Medicaids, they are state run programs that don't have coders, they don't have HIM professionals. So they're not really equipped to understand how all of this stuff is supposed to fit together, and that it's really not a static field, that it's constantly changing and moving, right? With
Right.
everything else, right? And a lot of times they don't even understand the depth at which these principles and processes and standards are ingrained at like the Medicare level. So they're really doing the best they can, but they don't know what they don't know. And so data governance in those environments is, if it exists now, it's very immature. They're really trying to get a grasp on what it means. If it's any stage of rolling into a data governance model, like you're implementing a data governance framework inside of your organization, then you're probably somewhere between, oh my God, we got to start all over. We have to scrap everything and start over because this isn't going to work. Or we have to figure out how to make all these legacy systems work within this model.
Which is the latter is what I've seen the most, right? Because nobody wants to start over, and especially IT. I mean, especially IT. They've
Yeah,
gone through SOC 2 and they know their systems are compliant with SOC 2, right? They don't want to start that process over. So it's more about fitting those legacy systems into that pattern, or those requirements, which is sometimes like fitting a square peg in a round hole, right?
yeah,
I mean,
yep.
it's really very much like that. Going back to the Medicaid not having and all of that stuff being static. Think about a cardiac catheterization. This is for coders. Seth, close your ears so they don't
Yeah.
bleed. But a cardiac catheterization in revenue code 360 versus 361, very different, right? Very different reimbursement structure tied to that. The rate is different. That is governing your data appropriately by putting the right charge on the right line
Mhm.
in that right revenue code for that same CPT code, right? That is
Exactly.
what that is. But to your point, going all the way back to who is the national steward of this reference data? How often does it get updated? So how often am I going to expect my systems to update? And then downstream of that, how often is every information system going to be impacted? And how many people touch each of those systems? And then of that externally, how many people are impacted by that? And can I verify that this whole data flow actually worked as expected so that the benefits are applied appropriately for everybody downstream of that steward printing a new or publishing a new updated reference set? It's
Absolutely.
incredibly challenging.
Yes.
And IT does a great job at what they call data governance. It is data governance. I'm not saying it isn't data governance. They do a great job at their components of data governance, but we
Yes.
have to overlay the context of our data
Mhm.
governance to theirs, right? Speak a little bit about that.
You are absolutely right. And that's one of the hardest conversations to have, is that systems tech, typically IT can be very possessive
Yes.
of data, right? And because they assume that because they are the custodians of the data, that they own the data and that they know the data. And the real challenge is explaining to them, but there's a part of that data you don't understand. And that's not a deficiency. It's just you don't, because you're responsible for the end stage of that process, right? Getting that data into the system, and making sure it goes where it needs to go, making sure that all the rules are set up appropriately to handle that data, transform it, whatever it is that you're doing, all of that stuff is set up. And that is valuable and that is important. But before it
Hmm.
even gets to that point, we're talking, what are the requirements for that data?
Yeah.
And that is directly related to, what are the business capabilities, the business processes or functions that data is actually supporting. Because ultimately what you're looking at is you have a policy that is being actualized or realized within an automated environment. And when you have that automated environment, you're not just taking in ones and zeros. You're taking in these data sets and these values that are strings of information. You know, a CPT code definition is a paragraph.
Yeah.
So it's not like a barcode where you just scan something and
Yeah.
here's your product. It's like, no, that is telling you something about what happened while somebody was in the care of this facility, this individual. Revenue codes, those kinds of delineations of what it means when you
Yes.
jump from one cost center to another is critical. You know,
Mhm.
there's all of these ways and these mechanisms in which these providers can explain what is happening. And when you don't have an understanding of all of that context, to your
Yeah.
point, Shannon, then you don't understand how that data should actually be treated. You're not going to treat it the way that it's supposed to be treated because
Exactly.
you are not aware of the context. And that is our biggest barrier in data governance from I think from a, maybe not just a public sector perspective, but when we're talking about the conversation that has to happen between data and systems. There is a piece that they do not understand, nor should
Mhm.
they. They're not. They're not HIM. They're not
Right.
HIM professionals. Why should they? We shouldn't expect them to know that.
Of course not.
But they need to understand that they have to know why something is happening and how it should be treated once it's inside the system, right? And the only way to
Absolutely.
get at that are your data requirements.
Yeah.
And data requirements are basically just taking what those business requirements are and converting it into a data. Like, this is the data set you're going to use. This is how you're going to use it. These are the edits that you should have in place to manage that data and process it. There's, these are the frequency limitations based on the descriptor of the code.
That's right.
All of those things that not nobody, but very few people have a grasp on. Those kinds
Seems like
of,
we've done a disservice by naming the
yes.
leader the chief information officer. And I worked in the IT world. I worked in IT in hospitals for years under a CIO. And as you're talking about this, my mind goes to the title's wrong. Chief
Yes.
Information Officer is wrong. They should be the Chief Technology Officer, Chief
Exactly.
whatever from that perspective, because they're providing the overarching function of technology, but they don't understand how to apply the context of the data in a true data governance program. In my brain, I'm a simpleton, so I have to break things down. That's how I made it through coding class. But I'm like, the CIO in any organization is like the owner of a farm. I live in East Tennessee, so I'm sitting here looking at more cows than people out my window. And the CIO is more the farmer, or not the farmer, but the owner of the farm that provides the equipment, provides the staff, provides the general
Yes.
structure of how this farm should operate. But the owner doesn't know the composition of the soil and the seasons that they
Right.
have to do and the amount of water. And that's where the farmer comes in, the person that understands that process. And to me, tell me if I'm wrong, but that's where I feel like the health information professional really has a strong place in data governance to improve overall quality of information. I guess that's the other question is if you have governance, does that ultimately lead to data quality improvement?
Mhm. It does. And it's one of the almost the side effects. It's side effect of data governance is data quality improvement. Because it comes hand in hand, right? The minute you start working on your data governance, then you start to see, oh, I have standards for this. So if I adopt these standards and every system that we implement is required to meet these standards from a data perspective, then that's automatically going to improve my data. On the public sector side, there's an entire mechanism for Medicaids to report monthly. If anybody's interested, it's called the Transformed Medicaid Statistical Information System, or TMSIS for short. And if you go out to Medicaid.gov, you can see TMSIS, and it actually gives you this big old map of the states and who's in trouble from a data perspective and who's doing okay, right? But any of those visuals are really not even an answer to what is actually going on within a system. It just means that they have either met benchmarks or they have not met benchmarks or thresholds.
Mm-hmm.
And so those are showing up as data quality issues. Now, you can take those and you can kind of reverse engineer, right, and figure out what your data quality issue is. 9 times out of 10, when you do that, you realize that it's because something is not set up right with the data in the first place. So let's take, for example, taxonomy codes, because that tends to be one that shows up a lot. Taxonomy codes show up, it's not valid, or it's not valid for the type of claim, those kinds of things. And it's coming through because there's no edit in the system that is saying, hey, is this data right? Great, it's complete. You've completed the field. Congratulations. It has all the expected characters. Congratulations. But it is not a valid code. Sorry, try again, right? But a lot of times they don't have that level of detail. Or, like I said, is that taxonomy make sense for that type of claim? Like if you've got a physician taxonomy that's coming in on a
UB.
I don't know. Yeah.
On a UB.
On a UB. You're not, that's not okay. That's a red flag, right? Those kinds of things are super important, but they get missed because, again, it goes back to, hey, we're paying the claim. Great. You're paying the claim, but what about all this other data? And that's coming in, that's required, or that is, maybe it's a situational data element, but the payer requires it. Well, if the payer is requiring it, you better be sending in the right data. And as a payer, you better be checking that it's the right data, that it is actually valid, right? So those kinds of things are super critical when you're talking about data governance, those standards, those requirements, and those eventually improve your data because you're just locking things down. You're putting up guardrails, you're putting up parameters and expectations on what I want to see, what I would expect to see in this data. It's not, by no means are you like forcing them to report in a certain way, but you are putting up guardrails that doesn't allow them to report something that isn't true, or that, that you're fat fingering something, right? There are checks and balances along the way to prevent that. But if you don't have data governance to kind of set up those systems that way, then it won't work. Then you're just running on faith. That's something that the people that are submitting that data are going to do it right every time. And that's
it's
just
kind of intentional collaboration plus quality assurance, right? Because you have IT with the systems, you have health information professionals with the data and the context itself, and then you have a team of people that do configuration, right?
Yeah.
So the systems, they know their role. The health information folks understand, or benefits folks, the people who are going to know how to apply the benefits for those particular codes for a self-funded group versus a Medicaid. You're to stay on track with payers, right? But then there's a team that has to put that into the configuration within those systems so that those benefits apply correctly. And they have to know that UB cannot accept that, place of service from a primary care physician's office, right?
Right. Yes, exactly. Yeah. Or you have to know that UB is expecting a type of bill and not a place of service. That is a real true story where, those are not interchangeable. You don't use place of service on UB04. It doesn't work that way, right?
Very good. Very good. Seth,
I think about somebody that's
so I don't know.
Yeah, it just makes me think of the folks that are not HIM professionals or HI professionals that listen to this conversation, because I do know of a few folks that listen to it that aren't in this, and I have to wonder if they think we're speaking in code when we talk about you being a taxonomy code and this, that, and the other. It's like, I bet they think we're from a foreign planet.
Yep,
Well,
they do.
and I will say too, Mandy, I appreciate the lobsters coming out of your head comment earlier, because being kind of forcing myself into the steering committee of data governance at a previous role, I had to ask an engineer. I said, do I not make sense when I talk? Because everyone either looks at me like I have three heads or they completely dismiss me. And she said, no, you make perfect sense, but you're 7 miles ahead of them. And they don't understand that they need to know what you're saying, and they won't until they get to the end of that road. And then they see, oh, shoot, we're missing this. And then they're going to remember, oh, wait, somebody tried to point that out before, but I can't remember who, because they were insignificant.
Because they didn't matter at the time. That is my personal experience. That is my personal experience. I have been consulting on this matter, on this subject for 18 years and trying to get some kind of traction. And it really hasn't been until, and this is no joke, it was COVID. COVID did it, which I thought was very interesting. So if we want to talk about stressors on a system that isn't really prepared and hasn't been set up, to manage data in this way, right? Which is, we need real-time data to understand what is going on. We need to be able to react quickly, implement benefits to accommodate the current situation, right? So that includes like telehealth. Everybody's now, whoa, we got to get telehealth straightened out, right? We literally went from not having a standard telehealth anything, like it was just like states figure it out, to everybody's got to come to an agreement of what telehealth is. We need a description. What is telehealth? What does it mean when you're doing something in a telehealth format? We need to know, the vaccines, all of those things that were happening all at that same time were all data. Everything was data. And so with that level of attention and focus, it became very clear that we did not have the infrastructure to support those needs, right? And so we have to react quickly, and we have to come up with mechanisms. So a lot of the visibility of it comes when people are forced to look at it, when they can't not look at it. It just isn't possible to not look at it, right?
Absolutely.
You are confronted with it.
You are. And standing up, during COVID, everybody stood up task force for their things, for operations. Sometimes there were new ICD or HIPcast or CPT codes coming out every week. And, sometimes configuration would take 60 to 90 days in big organizations. Well, you didn't have 60 to 90 days. That was an immediate. So there had to be basically an ops task force for implementing new codes that had to just skirt around. It actually didn't necessarily skirt around. It just really expedited the governance process for putting those codes into place, which really was wonderful. Seth, how are we on time? I don't know where we are.
Probably time to wrap it up. Okay. I'd say we're at that moment.
I can't see the timer now. So this is fascinating. And I love data governance and social determinants of health and rural health are my favorite things to talk about. So I could keep talking about this forever, but our listeners don't want to listen for that much longer. So, man, this has been so great, Mandy. Thank you so much for joining us. We appreciate your skills, your input, your knowledge here. Keep spreading that message of the importance of data governance from a context perspective. I love that you're making headway that you didn't make prior to COVID. And I hope that we can, as a profession, I'm hoping that we can now build more and more headway in that space to, everything is highlighted. And we know the healthcare takes 5 to 7 years to turn and start making something new. So when did COVID started in 2020? So we still have another couple of years before we start grasping this wholly, but maybe we'll all still be working then, or maybe we'll be retired. We'll see. So
I'll still
thank
be
you for
working.
joining
I
us.
know I'll still be working.
Yeah, thank you very much. And we do want to thank our sponsor today of this episode of HIPcast, Harris Data Integrity Solutions. Join us on a journey of excellence into the future of data integrity. Harris brings together the unparalleled expertise of Just Associates and QuadraMed Corporation to revolutionize healthcare data management. You'll have peace of mind that you are working with a SOC 2 Type 2 certified vendor. With SmartAct CMPI, you establish a single source of truth across your entire health system, ensuring accurate patient records with up to 99% accuracy. CuraMatch HIM workflow solution offers an automated HIM workflow, eliminating cumbersome processes of remediating duplicates using spreadsheets while reducing errors. Say goodbye to time-consuming MPI cleanup maintenance. Harris's expert team delivers tailored solutions for efficient MPI cleanup, customized to your facility's needs. Experience the power of Harris Data Integrity Solutions, shaping the future of healthcare data management today. Visit harrisdataintegritysolutions.com to learn more. Shannan, until next time, my friend.
I'll see you next time, buddy.